Hello and welcome to the Morning Report. Today we have a case of a 65-year-old woman presents in a comatose state and is brought into the emergency room. She has an acute history of fatigue and confusion according to her family, and the patient was recently diagnosed with small cell lung cancer about 2 weeks ago and has not yet begun treatment for that. She is currently on no medications and previously smoked 50 pack years, but quit smoking about 8 months ago. Her vital signs show that her blood pressure is 132/78, heart rate of 72, and respiratory rate of 18, and she's able to respond to painful stimuli and able to localize it. The patient is currently not on any medications. When we did a physical examination, her eyes would open when we called out her name. Lungs were clear to auscultation at axillary and anterior locations. Her heart had a regular rate and rhythm with no rubs, murmurs, or gallops. Her abdomen had regular motion with breathing and exhibited no fluid wave or discomfort as we were pressing there. Glasgow Coma Score, we gave an 11, and the lab report red flags that we saw was her serum sodium was 108 and her serum osmolality is 220. Her urine specific gravity on the UA was also 1.015 on the dipstick. Assessment: what is the most likely diagnosis in this patient, and what therapy should this patient receive? Also, what diagnostic tests should be run additionally? In this case, I really feel like the most likely diagnosis is hyponatremia-induced comatose state, and this is possibly due to a paraneoplastic tumor causing SIADH, or syndrome of inappropriate diuretic hormone. What therapy should this patient receive? Typically water restriction, and if SIADH, we also want to give some hypertonic saline infusion as well as some regular saline and monitor that closely. And then what serious problem can arise during treatment? In this case, it's central pontine myelinolysis, which is something we'll discuss further. So our clinical approach here, a couple definitions. Antidiuretic hormone, also known as vasopressin. It's a hormone from the posterior pituitary that is secreted to increase the reabsorption of free water, and it indirectly controls our serum sodium levels and our overall osmolality levels. What is osmolality? Well, it's the concentration of osmolar particles that determines the overall osmotic forces acting on our blood vessels and cells. What is syndrome of inappropriate secretion of antidiuretic hormone? This is just abnormally high levels of antidiuretic hormone, which causes reabsorption of free water in the collecting ducts of the kidney. This is usually seen with either a pituitary or pulmonary malignancy, such as cancer. Typically ADH is to help our kidneys determine how much free water we should reabsorb, but in this case we're always saying absorb as much free water at the very end of the collecting ducts. That way we end up dropping lots and lots of electrolytes, and we end up being very low on electrolytes in this problem. So our clinical presentation, it's an elderly woman in a stuporous state. Labs show hypotonic hyponatremia, and most likely she is euvolemic. Reason why we think she has a true volume is she's probably not hypervolemic, because on examination there was no JVD or peripheral edema, no swelling in her ankles at all, and she's probably not hypovolemic because there was a normal heart rate and normal blood pressure. There is no specific focal neurologic deficits we were able to determine, and a previous CT scan of the chest and brain showed that there were no hydrocephalus or brain masses when we were originally doing a cancer scan on her lungs. And then she was recently diagnosed with small cell carcinoma, which is often a neuroendocrine tumor in nature, and it's often associated with multiple hormone production problems, such as PTH for parathyroid hormone abnormalities, ACTH for abnormal glucocorticosteroid SIADH, which we're going to talk more about, and then Lambert-Eaton, which ends up being a problem in our nerves aren't able to communicate with their muscles. All of those are very commonly seen with small cell carcinoma. So hyponatremia, it is by far the most common electrolyte imbalance that we see on lab tests, and if you ever get it back, always double check, especially here in America, now that diabetes is more common, double check the glucose correction formula, because your true sodium is going to be your measured sodium minus 0.016 and then glucose minus 100. So basically, if you have really high glucose levels, your true sodium level is actually higher, but the glucose is taking up a lot of the osmolar forces at the time. According to the study I found, asymptomatic hyponatremia, they determined that 30% of elderly patients in nursing homes as well as a lot of other people are shown to have asymptomatic hyponatremia. So it is commonly seen on our lab results. And if we do get a case of a patient with hyponatremia, especially in this case where it wasn't just slightly low sodium but very low, we definitely gotta work up the hyponatremia and find the cause. We can't just jump straight to a treatment of, oh, their sodium is low, let's give them sodium. That could cause serious problems, and you're not truly treating the patient if you don't try to find out what the cause is before you treat it. Anyway, so first we want to determine if they're low in sodium, what about their overall blood plasma? Is it hypotonic, so low on electrolytes, hypertonic, so it's high on electrolytes and other osmolar molecules, or isotonic, where it's actually in a normal osmolar range, but we're just low on sodium due to other things taking place? If the patient is isotonic or hypertonic, chances are the hyponatremia is due to something else being there, either high triglycerides and fat, high glucose, or a previous drug, mannitol, infused in their body. If they are hypotonic hyponatremia, then we definitely have to worry about, well, what's causing this? Is it something in the kidneys, or are they sweating too much? We need to determine what is the underlying cause of why their blood plasma isn't within the right osmolar range. A couple things to help us figure this out is we want to determine, well, what is their total water content in the body? Are they hypovolemic, so they're low on water? And the signs of this are going to be an increased heart rate and decreased blood pressure. There's just not as much fluid, so the heart has to work much harder. Are they hypervolemic? This is going to be where we see lots of swelling in our ankles. We see our JVD, or our jugular venous distension, or the vein in our neck, is really dilated and huge. Or is it euvolemic, where we have regular vitals and physical exam, we can't see something points us either towards too much water or too little. Then by a diagnosis of exclusion, it must be euvolemic. Anyway, so quick thing, if we do get a patient who is hyponatremic and hypotonic, we can have a flow chart to help us organize our brain and map out, okay, what could be the problem here? If we are water deficit, then, or on the left side here, we have hypovolemic. That is, our total body water is low and our total body sodium is really low. Some of the causes for this will be explained later. Then in the middle path, this is slightly excess water. We call it euvolemic because on physical exam, we didn't notice anything pointing towards too much body water. And in this case, usually we have too much water and a normal amount of sodium in the body. And for these patients, we just need to put them on some type of water restriction to help them drop the extra water. And then lastly, a sodium and water excess. These are going to be the patients we see lots of swelling, other problems, and there are possible causes. We got to look at both non-renal and renal causes. Anyway, just want you guys to look at that flow chart and see how we are mapping this out exactly. Whether a patient is hypovolemic, hypervolemic, or euvolemic, we are going to measure their urine sodium to help us know, are we losing sodium in the kidneys or are we losing it elsewhere? So if our urine sodium is greater than 20 milliequivalents a liter, then that's a pretty good sign that we're losing lots of sodium in the kidneys, and we shouldn't be because we're hyponatremic here. So a common cause of this, especially in the hospital, is we've put the patient on loop diuretics, and then Bartter syndrome is a syndrome where there's a genetic defect that makes it so the patient acts like they're always on loop diuretics. And that is usually seen with low potassium, low calcium, low magnesium, low chlorine. All our electrolytes are pretty low. And then thiazide diuretics, the big thing we'll notice here is we're going to have a normal calcium level. Again, other possible causes, ACE inhibitor or angiotensin receptor blocker or aldosterone deficiency is also a possible cause, not nearly as common. And then there's also cerebral salt wasting syndrome. The mechanism, we are unsure of what it is exactly, but the belief is that high BNP released by the atria of the heart causes our body to drop lots of water, and then low aldosterone levels leads to the hyponatremia because we're not reabsorbing salt in the collecting ducts of the kidney, or the distal portion of the kidney. If our urine sodium is really low, then that means that our kidney is appropriately responding to a low sodium situation, and our loss of sodium is probably somewhere else. Oftentimes, sweating is by far the most common reason, but also vomiting, diarrhea. In those cases, look for other electrolyte abnormalities, especially the potassium level. And then also burn victims. They are going to lose a lot of water, get dehydrated, and lose electrolytes after a burn. A patient that is hyponatremic, so low on sodium, but has a normal volume status on physical examination, the first thing we're going to look at is a low urine osmolality. Again, if the urine has very low sodium in it, we're going to think, okay, it's probably not the kidneys, it's somewhere else. And if they're euvolemic, we typically think this is more psychogenic, or such as beer drinkers' potomania. Patients drink lots and lots of beer, but they're not getting enough electrolytes by eating other foods with it, and this leads to a situation where we're overloaded with fluids. So even though the kidneys are saying try not to lose any sodium, we still lose some sodium in the kidneys, and we're getting way too much fluid levels that eventually the sodium just drops off. Also, psychogenic polydipsia. These are patients who are drinking 10 to 20 liters a day of water. Commonly, we need to get a psychiatric referral for these patients. They're just drinking too much water. Their kidneys can't balance out the sodium when you're bringing that much water on board. In these cases, treat with a water restriction. And then there's also high urine osmolality. And that is in a euvolemic patient. This usually leads us towards the diagnosis of SIADH. SIADH patients may also be hypovolemic, but usually we think of that as cerebral salt wasting. It could be either way. SIADH has its own treatment, as we'll go over later. Anyway, too much ADH, it'll open free water reabsorption at the very end portions of the kidney, causing our body to absorb all this free water, and all the electrolytes are stuck in the urine and end up getting dumped out. That's what leads to the low sodium, because we're absorbing free water at too late a point to absorb sodium with it. Anyway, lastly, if we're hypovolemic, so we got way too much water on board, we want to look at, is there too much sodium in the kidney? If there's still lots of sodium in the kidney and we still have too much water on board, then we're in kidney failure or have an acute kidney injury. Our kidneys aren't doing enough of what we need, aren't filtering enough, aren't getting rid of enough fluid. We need to help the kidneys out. And then if the patient has really low urine sodium and they have hypervolemia, then this is often a problem with third spacing. We're getting too much fluid is third spacing in cells and tissues outside of the kidneys throughout the body, whether it's fat tissue, in interstitial cells, wherever it is, extra fluid's being lost there. This is commonly seen with congestive heart failure or low protein states such as liver disease. We're not producing enough albumin, so we don't have enough of an osmotic effect to bring fluids back into the blood vessels, or nephrotic syndrome where our kidneys are dumping protein, and in that case our liver can't keep up, and eventually we don't have enough protein to pull water back into the capillaries before they head back to the heart, before the fluids head back to the heart. So how do we treat hyponatremia? Well, let's look at the bottom half of the graph I showed you earlier. If we're hypovolemic, hypotonic, of course, all these conditions we're talking about, you need to be hypotonic, and low water levels, then we know that we have a total body water is down and our total body sodium is really down. So in both of these cases, we're given an isotonic saline, and we need to treat the underlying condition and stop it. For patients that are euvolemic, we're just slightly up in body water, so we're going to put them on a water restriction. And those who are hypervolemic, way too much body water, also, even though we put them as hyponatremic because their sodium concentration's low, if you look at the fact that they have way too much water in excess as it is, they actually are slightly increased in sodium. So these patients are going to have both a sodium and a water restriction. We'll explain it in more detail. So hyponatremic, hypotonic, general treatment, just went over that. The most important thing is you gotta treat the underlying etiology in each, and the treatments here: isotonic saline water, water restriction, and water and sodium restriction. Those work as general guidelines on how to start out, but in reality, you need to treat towards the underlying etiology and be much more direct towards it. We're going to cover the underlying etiology of SI-ADH. So SI-ADH, again, this is a disorder where we're producing too much of the hormone ADH, also known as vasopressin, and this can be caused by almost any CNS disorder, central nervous system. Also, pulmonary diseases such as small cell cancer, like in the patient we talked about earlier. And then there's also some medications can cause this. Often they're psychiatric medications given to patients. SI-ADH is a diagnosis of exclusion, so look for high urine osmolality in a hyponatremic patient, and usually they're euvolemic, they may be on the hypovolemic side. The SI-ADH can result in severe neurological symptoms if the sodium levels fall below 120, and these severe symptoms include seizures, coma, inability to communicate with others. They look really confused. Sometimes when they're talking to you, they'll sound confused, or they'll just maybe say words that don't really work together. Sometimes it's just sounds, and you know this person knows how to talk, but with the really low sodium levels, that does things that makes it inoperable for your brain to correctly communicate with itself. The initial treatment in patients brought in with SI-ADH is we want to give 100 milliliters of 3% saline solution in 10-minute intervals, and this is if they're having severe symptoms. We want to give this and resolve the severe symptoms because they are in danger with those severe symptoms. After doing it 3 times, then we hold back, even if they still have severe symptoms, because we don't want to give too much saline, as I'll talk about in a bit. And then careful monitoring of the serum sodium every 2 to 3 hours. Follow regular treatment guidelines for the hospital, follow standard of care, and if a patient has a urine osmolality of greater than 500 milliosmoles per liter, you can initiate a loop diuretic. And this has a paradoxical effect of usually you're worried about losing too much sodium here. Well, it's better that we're losing water with the sodium than if a patient is only SIADH. If they don't have a loop diuretic, then we're still going to lose sodium at the end of the collecting ducts, but we're going to reabsorb as much of the free water as we can. By giving loop diuretic, we're going to minimize the counter current osmolality, and this, paradoxically enough, actually helps treat the patient with severe SIADH due to we're now losing water with the salt we're losing instead of just losing salt and no water. That was kind of a simplified version. Definitely, if you have some free time, look up the paradoxical effect of treating SIADH with loop diuretics. There's also diabetes insipidus. There's a paradoxical effect of treating that with hydrochlorothiazide. Also a very interesting read. It'll help you really understand the physiology and the pathology of the disease. And once you learn that, you will definitely know how to treat that going forward. Next, acute SIADH symptoms. These are short-lived symptoms, very recent developments. Family members can tell you, oh yeah, they were normal just 2 days ago. Or even better, they were normal 3 hours ago. In these cases, we can give saline quicker because the brain hasn't slowly adapted to the lower hypotonicity levels. Whereas a chronic situation, the patient has, over time, developed a brain normality towards these really low hypotonic situations and low sodium levels. And if we give too much at once, then we'll cause portions of the brain to swell and we can damage them. Anyway, so as you can see here, patients who have acute symptoms, we can give saline a little bit faster, raise it by 1 milliequivalent per liter each hour, and sometimes a loop diuretic will be necessary to achieve this. In other patients with chronic SIADH symptoms, we can only raise the serum sodium level by 0.5 milliequivalents, and this is to help protect against central pontine myelinosis. What is the maintenance therapy over a long period of time? Well, fluid restriction, less than 800 milliliters of water each day. We also like to add an oral salt intake to make sure they don't end up hyponatremic again. And last line is loop diuretics. We can use these up to twice a day. Beware, they will cause electrolyte imbalances such as low potassium and also low total water level. So you need to have these patients constantly monitored if you go that level. There are drugs to help directly combat the increased ADH levels, but they're prohibited due to cost, increased thirst, and there is a huge list of side effects, but most importantly, there is an increased risk of neurologic side effects. So what is central pontine myelinosis? I've brought it up a couple times. Let's talk about it. The main thing is the cause is rapid overcorrection of serum sodium. If we have a patient comes in at a sodium level of 110 and you're like, that's not good, let's bounce them right back up to a normal sodium serum concentration of 140, and we do that over an hour or so, this rapid overcorrection will cause damage to the brain and mainly the brain stem. And unless there is severe symptoms, we need to slowly infuse saline solutions and use water restriction. The slow infusion of saline solutions plus water restriction helps guarantee we won't overcorrect too fast. And what's the pathophysiology? The brain over time will adjust to sodium levels by gradually increasing and decreasing intracellular osmolytes. I don't know if this is proven or if it's just theory at the moment, but these osmolytes in acetyl, betaine, and glutamine, each of them take a long time to increase or decrease, so the brain needs time to increase its osmolytes to keep a normal fluid level. And if we overcorrect sodium too fast, then we will damage the brain. So, what's the treatment? Prevention is the best treatment. in the hospital, our goal is to do no harm, so follow saline infusion rates very closely. Once osmotic demyelination has begun, there is no specific treatment or known cure, but there are supportive therapies we know about. You can give vitamins and minerals. Early ICU intervention with breathing and feeding assistance ready to go has been shown to really help keep the patient alive. Thank you so much. I hope you learned something and have a great day.